going to go ahead and move forward with the next lecture. We'll talk about fetal abdomen. So it's just a review of normal anatomy, variants, and then anatomic defects. And it's just, we're not going to be able to cover all of the anatomic defects, but we'll go over the major ones. So the objectives: review the normal anatomy of the abdomen, discuss the GI tract and its abnormalities. We're going to describe abdominal and ventral wall defects, list the common abdominal masses detected in utero, and then discuss some of those variants and pitfalls. So why are we looking at the fetal abdomen? Well, it's a common site for birth defects. Birth defects of the abdominal wall have a high association with chromosome abnormalities. The antenatal diagnosis can improve your fetal outcomes. If we know that there's an abdominal wall defect, make sure that they get to a tertiary center to be delivered. It provides a chance for early neonatal treatment and allows consideration for in utero intervention. The fetal abdomen, when we look at it, this is looking at a coronal. So we want to look from the chest all the way down to the pelvis. So it gives us a nice outline of the diaphragm, the heart, so we can assess the liver, the bowel, and all the way down to the bladder. So from the diaphragm to the pelvic floor, and there's dynamic structures, there's changes going on in the abdomen throughout the pregnancy. The echogenicity changes throughout the pregnancy, and it's very important for us to know what our landmarks are and allowing for situs check. We'll look at the GI tract, the liver, the spleen, the gallbladder, pancreas. Most of the time you're not going to see the pancreas. Genitourinary tract, and then looking at the mesenteric peritoneal cavity. So we want to assess the abdomen in 3 planes: a sagittal, transverse, and a coronal. And I really love this coronal view. It really helps with the assessment of that. And when you're looking at this, remember there are 2 hypoechoic structures in the abdomen, so you want to see the stomach and look for the gallbladder also. You want to confirm your situs. So you're going to identify, how the baby's laying, document on your image if the baby's breech, cephalic, or transverse. And then you're going to label both the stomach and the heart. Here we're looking at a transverse of the abdomen, so we can see the posterior wall here and the anterior wall here, left side down, right side up. And I just point out that, if you think that your stomach is off axis, make sure that you're looking at stomach and not gallbladder, because sometimes that gallbladder confuse you. One of our biometries, looking at the abdominal circumference, we want to make sure when we're looking at this, you see just one rib on either side. When you see too many of them, then you're oblique. So it's another guideline when you're assessing your abdominal circumference. We're going from posterior to anterior, and this abdominal circumference is around the periphery of the abdomen. You can also add color, helps us to identify that umbilical vein coming in curses away from the stomach. It should not be going towards the stomach, because then that would be a right umbilical vein. We want to look at the renal location. So the best assessment for this is with the spine up, so you can see both kidneys on either side of the spine. If you can't get this view, then use your split screen. Usually if you have 2 of an organ, then try to put them side by side so you can compare them. So then you can document one kidney and go to the other. So a good rule of thumb when you're looking at the kidneys is you should be able to put 3 of them in the abdomen. If it looks like you could put 4, then maybe those kidneys are too small. You should probably measure them. Or if it looks like it's taking up half the abdomen in the AP projection, then they're too big, and again, measure them. So anytime they look bigger or smaller than being able to fit 3 in there, you want to make sure that you do go ahead and measure the kidneys. And a lot of these measurements, I know the charts change depending on what charts you want to use. We actually just go to perinatology.com, and they have most of your calculations and all your charts right on there, and they update that the most frequently. It's free to everybody. So, that's a good way if you're doing those measurements, go online and just check, make sure they're in the normal range. So we'll talk about the GI tract, some of the embryology. The gut forms about the end of the 5th menstrual week. There's 3 parts to the GI tract. We have the foregut, the midgut, and the hindgut, and we'll look at each of those. The foregut has the pharynx, the respiratory tract, esophagus, stomach, proximal duodenum, the liver, and the pancreas. The midgut is your distal duodenum, small bowel, and proximal large bowel. And then the hindgut is the distal large bowel, rectum, and portions of the vagina and bladder. So the small bowel, remember in early embryology, we can have that bowel that herniates out of the peritoneal cavity into the proximal segment of the umbilical cord. It makes a 90-degree rotation. That's called your physiologic herniation. So don't be calling it omphalocele or gastroschisis in the first trimester. And this does happen still, where people, get all excited that there's an omphalocele early on, and it's just the physiologic herniation. So what do I see, and what gestational age am I at? So at about 10 weeks gestational age, returns into the abdomen. It's rotating another 180 degrees counterclockwise, so a total of 270 degrees that gut is rotating. Your intestinal peristalsis starts at about 11 weeks, and swallowing starts at about week 11 to 12. So fluid goes through the small bowel and gets reabsorbed in the large bowel. We have the residual material in the large bowel, which is the meconium. And so this is just some of the cells, the mucoproteins, lanugo hair, urea, steroids, vernix. So it's a hodgepodge of different things that's sitting within that intestine. Bowel peristalsis is bidirectional in the second trimester and then unidirectional in the third trimester. So this is another thing you can look at. Bowel echogenicity in the first and the second trimester. The echogenicity can be ill-defined area in the middle of the mid to lower abdomen, right in here. So this is liver here, there's stomach, nice diaphragm. So this is your bowel here. The large bowel is a continuous, tubular, long abdominal, it's along the abdominal periphery, just kind of outlining. If you're thinking like when you're younger and you color the inside, that's the small bowel, and the large bowel is the bright border around it. So it's hyperechoic and usually no peristalsis. So it's looking at some of your bowel. The difference is the small bowel is more central located, more echogenic, and peristalsis is noted. So those are your two big differences between your bowel. Small bowel size increases with gestational age. The usual diameter should not be greater than 5 millimeters. The length, one segment should not be greater than 15 millimeters. The large bowel progressively fills with meconium. Normal diameter at about 20 weeks is 3 to 5 millimeters, and that term shouldn't be greater than 20 to 23 millimeters. So you can see how this does enlarge and change over size. So now if you get a new machine and all of a sudden you're looking at the intestine, because of the better detail, we're seeing so much more. So I caution you that when you have a new machine, to get used to your settings, and because we can always tell when a group has gotten a new machine, because all of a sudden they're sending us all this abnormal bowel. Be careful with your settings, because you can make every baby's abdomen and bowel look abnormal just because of you're not used to seeing that type of detail. So just be cautious. Make sure that you're not overcalling things. So fetal stomach is seen at about 12 to 15 weeks. So it's an anechoic structure on the left. The wide ranges in shape. It can be round, oval, kidney shape. Size ranges from 4 millimeters to 4 centimeters. It has variable rates to fill and empty. Good rule of thumb is always look at the bladder and the stomach in the beginning when you're doing your initial survey of that uterus and the adnexa. Just kind of, go, oh yes, I do see both of them. And over the time of your scan, it should have changed. Transvaginally, the stomach can be seen as early as 9 weeks. So greater than 1 centimeter in the second trimester and the third trimester. You want to make sure that you are having, if it's less than 1 centimeter, then you can call it a small or decreased size to the fetal stomach. Non-visualization after 19 weeks is always abnormal. So if you don't see the stomach, then you start thinking of an upper GI obstruction. And if you see that, then you should start to see an increase in your fluid also. So just looking at different presentations of the stomach. Sometimes if there's been some bleeding in the pregnancy and there's blood that's floating in the amniotic fluid, then you can actually get some debris sitting inside the stomach. Just the different presentations. So it's very variable. This one actually had a little bit of clot sitting in the stomach. It can be, a small stomach can be seen with your high GI obstructions, so a mouth to the esophagus. Severe neurologic or muscular abnormalities, because the brain is not sending the signal down to the baby's mouth so the baby's not swallowing. So any of your neurologic or muscular abnormalities. And then you can have a narrowed or compressed chest, thoracic or neck mass, any of these things that can prevent the baby from swallowing. Or if you have a defect or a mass in the fetal mouth, sometimes with clefting, the stomach size is going to be a little bit smaller, especially if it's a big midline cleft. Baby's swallowing, but the baby's trying to swallow fluid and the fluid's coming out back through the defect. So these are some of the reasons why you can have a small defect. So in esophageal atresia, the incidence is about 1 in 2 to 3,000 live births. 30 to 70% have congenital malformations, so cardiac, other GI, GU, skeletal, or chromosome abnormalities. 40% will have IUGR. Incidence for high obstructions for the esophageal atresia is 3 times higher in twins or multiple gestations. They only detect about 50% of our cases that we'll see with esophageal. So some of these we're just going to miss. I mean, ultrasound is good, but it's not perfect. Esophageal malformations, the atresia, classic presentation, about 8 to 10%. With a tracheoesophageal fistula accounts for about 88% of our cases. So it's a combination. So with the classic atresia, you're going to have polyhydramnios and a small to absent stomach bubble. And just with the tracheoesophageal fistula, only half will have a non-visualized stomach. And then they'll have a later onset of polyhydramnios. So remember, in some of these TE fistulas, you're really not going to pick them up because you're going to have a normal sized stomach. So your first clue that there is an upper GI obstruction is when you have that small stomach, but not all of these TE fistulas are going to catch our eye just because the stomach still looks normal. We have VADR or vactral association, and we'll go through what these mean. So V for the vertebral defects, anal atresia, tracheal fistula, esophageal fistula or atresia, and then renal abnormalities. So that's your VADR. So again, the more abnormalities you see, then you start looking for these syndromes or sequences. And then if you add the cardiac and the limb, then that's the vactral. So once you see one defect, look around, scour around everywhere else to make sure that there's not another defect. And the more you see, the greater the chance of aneuploidy or a syndrome. So a duodenal obstruction, that's when you see 2 cystic structures in the abdomen, your classic double bubble sign, so cross-section of the abdomen, posterior to anterior, left to right. So I don't think I've ever seen a gallbladder round like that. So again, you just watch. You see what's going on over time to see, how far this fluid that's in the intestine progresses and if it's going back and forth. So you'll have a dilated stomach and dilated proximal duodenum, and they communicate with each other. The earliest that we can see this is 18 to 20 weeks, but usually not seen until after that 27, 28 weeks. Polyhydramnios, you can see it usually by about 24 weeks, but sometimes you don't see it until later in the pregnancy. But eventually, polyhydramnios will develop in about 50% of your atresias. So there's different causes for the obstruction. There's intrinsic and extrinsic causes. Intrinsics is when there's an actual structural abnormality, atresia versus a stenosis. Atresia in about 42%, stenosis in about 38%, or sometimes you can have this diaphragmatic web, which is about 10%. So this is actual obstruction that's causing the duodenum to enlarge. And then the extrinsic causes would be an annular pancreas or a malrotation. So the karyotypic abnormalities or other malformations or both are found in about 65% of these babies. Most common, it's the most common perinatal GI obstruction that we see. 30% will have Downs. So again, there's one of your markers. But again, when we're doing that genetic screen, is about 18 to 22 weeks. So a lot of these it's not one of the markers we can really rely on because we may not see that patient again, at 27, 28 weeks. They have an association with congenital heart disease, 25 to 35%, so VSD and AV canal, and then vertebral anomalies in about 33%. So your echogenic fetal bowel, so looking at a coronal of that abdomen, so this bright area, it says bright as bone. So you can compare it to the iliac bone, to the femur, the spine, whatever you can line up with it. It has a mass effect, so you can see how this area looks a little clumped and brighter than what it should. Usually the right lower quadrant or left lower quadrant. It's abnormal if it's greater in 4 centimeters in size. So here's just one little area of the bowel that says bright. The rest of the bowel looks okay. We see stomach here, liver here, and then this area here. So it's seen in association with, again, cystic fibrosis, Down syndrome, CMV, parvo, GI obstruction, swallowed blood, intraamniotic hemorrhage. So it's, one of the routine questions that we ask the patient when they come in, besides, their gravida and parity, is any previous vaginal bleeding in this pregnancy, any leaking of fluid, any high blood pressure, any diabetes, especially the bleeding part, because if they've had vaginal bleeding, then there's a chance that there could be some of blood in the amniotic fluid, and so then I know that I may see increased echogenicity to the bowel. So again, just always keeping in mind your patient history. It can also be seen in severe IUGR, and most of the time it's going to be a normal variant. So if you see it, start looking for other things. So jejunal and ileal atresia that occurs in about 1 in 2,700. It's more common in occurrence than duodenal atresia. It's a lower perinatal detection rate because, again, we're not going to see it until 24 weeks or later. It's easier to see in the 3rd trimester. Jejunum approximately 50% and ileum about 43%. Any of your bowel obstructions, any of your GI obstructions are going to have a higher association with polyhydramnios. So small bowel, again, the diameter greater than 7 millimeters, dilated bowel loops into the hyperperistalsis. Nothing else. This really catches your eye because you can see that bowel just moving around back and forth. And then if there's a perforation, then you can get actually ascites. So this was ascites on this baby that we had and what we thought earlier was an obstruction, and then later on this baby did develop ascites. So some of the causes for small bowel obstruction will be the atresia secondary to a vascular accident, the stenosis or narrowing of a segment of the bowel, a volvulus and interluminal sludge and no peristalsis, and the meconium ileus. And the meconium ileus has a high association with cystic fibrosis. You have echogenic small bowel in the 2nd trimester, and then later on dilated fluid-filled loops, and then echogenic dilated bowel, and then an abnormally small colon size. So there's just too many cystic structures in here. Here we can see stomach here and gallbladder, but we've got too much else going on in that abdomen. So that should be telling you, I need to look at this. And then we're looking for peristalsis. Is it part of the GI tract, or the other thing it could be is something in the kidneys if it's a dilated ureter. So you really need to take a close look at that. So meconium peritonitis is about 1 in 35,000 live births. There's increased risk for in utero bowel perforation or rupture, associated again with cystic fibrosis in 10 to 40%. And the other big one would be infections, CMV. And 80 to 85% will develop intra-abdominal calcifications. So these bowel obstructions will have a high association with your abdominal calcifications. Other signs that we can see with meconium peritonitis: dilated bowel, the ascites in 50 to 55%, the meconium pseudocyst, where you just see this cystic structure and you can't really connect it with anything, then well, that may be meconium pseudocyst. That should be part of your differential. The polyhydramnios again, and then the echogenic debris within the ascites. When you see the echogenic debris in the ascites, think more of some type of a perforation or meconium peritonitis. Just looking at the abdomen, so this is one of those meconium pseudocysts. You're like, okay, what is this? So you're looking at a little bit of the stomach and then part of the liver. Well, now I've got some calcifications here. So now I'm thinking, okay, now this is probably going to be some type of a bowel, a perforated bowel or meconium peritonitis where I have a cystic structure. Now, if I'm looking at this for the first time and I see, and it's a female fetus, the first thing I'm going to think is that it's ovarian, because ovarian until proven otherwise. But when it's up higher and then you also see the calcification, then start thinking more of the GI tract. Usually your ovarian cysts are not going to have any kind of calcifications with them. So again, what do you see? Where do I see? What else do I see around it? Large bowel obstruction accounts for about 5 to 10% of your bowel atresias. Anal atresia is the most common. It's usually secondary to a vascular insult. 75 to 80% will have other abnormalities. So this whole segment of bowel that's dilated here. Just too many cystic structures within the abdomen. Always put on color, make sure that it's not a vascular abnormality, and then measure it. So abdominal cysts in the right upper quadrants. Well, when we think about the right upper quadrant, we think, well, is it liver, or what else could be up there? Well, what about a choledochal cyst? Left upper quadrant, we think of splenic cyst. And posteriorly, anything posterior around the spine, then we think of being kidney in origin, whether arising from the kidney or the adrenal itself, or then part of the ureter. And then mid-anterior, think of the mesenteric or umbilical vein varix, so a mesenteric cyst, if it's in the mid-anterior segment. So here's bladder here, coronal view again, looking from the diaphragm, the stomach and the liver. There's looking at the bladder, and now we have this cystic component that's occupying the majority of the middle of the abdomen. That was a meconium pseudocyst. All right, choledochal cyst is a dilatation of the common bile duct. It's separate from the gallbladder, so you'll see the stomach, you see the gallbladder, and then you see this rounded area right at the area of the bile duct, right near the gallbladder. Does not communicate with the stomach and may communicate with other dilated bile ducts. So you really want to look at that liver to see if there's any dilated bile ducts, because normally in utero you should not see dilated bile ducts. Choledochal cyst may not be seen until after 25 weeks or later. So even out here, just again, too many cystic structures within the liver, and there was that cystic structure, and we did trace it back, and it was a choledochal cyst. I mean, even look how you have the posterior enhancement. Just like any cyst anywhere in the body, you should have the posterior enhancement. In the lower abdomen, again, if it's female, think ovarian. Until proven otherwise, you think it's ovarian. Because remember, these can actually get big enough where they torse and they can auto-amputate. So you may see it, one time you saw it in the right lower quadrant, next time you see it in the right upper quadrant, or you see it in the left lower quadrant. So these ovarian cysts can be big enough where they torse, they twist, and they auto-amputate. Okay, then other thing that we think about in the lower abdomen would be a ureteral cell. They can be very tortuous, but you differentiate them by looking at them over time, because if it's GI, you should see peristalsis. With a ureteral cell, you're not going to have any peristalsis. And then the hematometrocolpus, just the dilated uterus. So looking at here's the bladder, and this is looking at the area of the right ovary. And then other abdominal cysts, we want to just document, you may not know what it is. You can just describe what you see. I see this cystic collection in the left side of the abdomen. I describe the shape and the size and the position, describe the wall contour and thickness, and if it has any posterior enhancement or not, if it has any shadowing, are there any calcifications around there. This one was referred for, they were saying it was an abdominal, a GI obstruction is what they were saying, but what do you think this is? Look, this is posterior to anterior, and this is going to be right to left, and they were saying a GI obstruction. What do you think that could be? It was kidneys, dilated kidneys. So umbilical vein varix is one of the other abnormalities that we can see. It's a developmental abnormality. It's a focal dilatation of the intra-abdominal part of the umbilical vein. It's usually near the cord insertion, and it's abnormal if the internal diameter is greater than 9 millimeters or twice the size of the intrahepatic portion of the vein. So normal size at week 20 is about 3 to 4 millimeters and can increases with gestational age all the way up to about 8 millimeters at term. So what you want to do is, if you think it's an umbilical vein varix, then you go ahead and put color on it. And if it truly is a varix, then you tend to have a little bit of turbulent flow in there. So this is looking at the stomach. This is not gallbladder. That was right as the umbilical vein came in, and it was greater than 9 millimeters. It was 9.5. And then we're comparing it to the intrahepatic part. So the intrahepatic part was 3.4. So if it's twice the size of the intrahepatic part to the umbilical vein, then it's an umbilical vein varix. So it's just like you have with an artery, you have an aneurysm. With the vein, you have a varix. It's a focal dilatation to that part of the vein. And so again here, 9.8. So the color really helps you identify, what the borders are. And you are measuring those inside, from the inside of the wall. So this one was measuring 10 millimeters. So, and if you see umbilical vein varix at the cord insertion into the abdomen, the other place you want to look, cord insertion into the placenta, because you have a varix in the abdominal wall, you can have a varix over by the placenta side also. So you try to follow the cord as much as you can. You can have them anywhere, but yeah, specifically make sure that you do check cord insertion into the placenta also. And they're just putting some color on there. It can be associated with chromosome abnormalities, Downs, 18, and then trisomy 9, congenital malformations. They can be associated with decreased growth, hydrops, and then what we worry about is them getting thrombosis in that area. So you check the placental insert for a varix, and if it's isolated and you don't see anything else, most of them come with a normal outcome. So we will follow them for growth, make sure that there's good growth and good fluid. And if they follow along a normal pattern for that, we're expecting a good outcome. Okay, your normal liver occupies a majority of the upper abdomen. And remember, in utero, it's the left lobe of the liver that's larger than the right. So when that umbilical vein is coming in, what it's dumping into is actually the left portal vein, and then from the left portal over to the right. It's a greater supply of oxygenated blood. The umbilical vein empties into the left portal vein and curves away from the stomach. So that should be key. This is one of your images you're getting for your biometry. So always make sure that that is curving away from the stomach. Ductus venosus shunts the blood from the umbilical vein directly into the IVC or the right atrium from the umbilical vein. So this is one of our shunts that we'll look at when we're assessing for twin-to-twin, because it really is giving us a lot of information as to, especially with the recipient, how is that recipient doing? What is the load on that fetal heart? So it's looking at a cross-section of the abdomen again, and this is looking at the umbilical vein as it's coming in. And we're going from the umbilical vein to the left portal to the right portal. And it comes in and it curves over towards the right side, so away from the stomach. So in early embryology, there's 2 arteries, 2 veins. So there are 2 umbilical veins in the beginning. If this one, for whatever reason, does not develop normally, then we end up with what's called a persistent right umbilical vein. So it'll come in, it looks like it's pulled over towards the right side a little bit more, and your big clue is that the gallbladder is going to be medial the umbilical vein, and it comes in and then curves back towards the stomach. So there are variants of this. All right, looking at the anatomy of the ductus venosus. So we have the umbilical vein coming in, and then looking at the ductus venosus as it's going to be shunting the blood back up into the heart. Increased liver size, there's different charts, and remember the size of the liver is going to change with gestational age. It can also be seen increased size with fetal hydrops, hemolytic anemia, some of your congenital infections, and then some of your syndromes, specifically the Beckwith-Wiedemann syndrome, where you have the enlarged liver, the macroglossia. Persistent right umbilical vein, again, is a rare anomaly. Normally atrophies about 6 to 7 weeks, but the umbilical vein connects to the right portal vein. The portal sinus, again, curves towards that stomach. And your big clue is that the gallbladder is medial to the umbilical vein. So the umbilical vein comes in, but it looks like it's curving over towards the right. And when it's actually curving back to the liver, it's going towards the stomach instead of away from the stomach. It can be associated with some other malformations, cardiovascular, central nervous system, renal or skeletal. But if it's isolated, again, it's probably just a variant of normal. Again, we would just follow them for growth and make sure they follow along a normal growth pattern. So one of the things we can look at is liver calcifications. Incidence about 1 in 1750. They can vary in size and location. They can be on the liver surface or peritoneal. It can be vascular or subcapsular from an ischemic event, or it can be parenchymal, actually within the tissues of the liver. And when you have that, that's usually from a congenital infection. And the more common infection that we would see would be the CMV, herpes, and then toxoplasmosis. It can be associated with abnormalities of the GI, GU, and cardiac systems. So this is looking at a cross-section of the abdomen, looking at posterior to anterior, left to right, and you can see throughout this liver we have these calcifications. And if you see calcifications in the liver, where else should you look? Up into the brain also. So we went ahead and did infection titers on this patient, and she did have a CMV, a primary CMV exposure. So liver masses, the right lobe is more often involved. The most common solid lesion in the neonate, it's a hepatoblastoma, the metastatic neuroblastomas. In utero, the neuroblastoma is the most common mass that we'll see. So 90% are in the adrenal gland, 60% will be on the right, 50% are cystic, 50% will be solid or complex, and it's the most common congenital malignancies, the neuroblastoma. The most common vascular tumor that we see is hemangioma, and could be hyper or hypo or mixed echogenicity. So you can see there's different appearances to the same type of a mass. And then in utero, this hemangioma is going to grow and then act like a big AV shunt, drawing blood away from the baby's heart and putting that baby at risk for high drops and delayed growth, or it can actually outgrow its blood supply and start to involute. And it'll get smaller and smaller and then end up appearing just like a little echogenic area within the liver. So, and hopefully that's what happens, because otherwise these kids are at risk for problems because of the big AV malformation. All right, so gallbladder, it's usually seen about 12 weeks of gestation. It's anechoic and ovoid in shape. It's usually lateral to the umbilical vein. And we can see it in about 80 to 100% of the second and third trimesters as long as you're looking. I mean, I'd say, 80 to 90% of the time I can pick it up very easily. Agenesis of the gallbladder can be associated with some of your duodenal atresias, biliary atresia, polysplenia, and some of your rare syndromes. You can have gallstones that you can see or sludge. Most of these little gallstones that you see are going to spontaneously resolve during the neonatal period or the first year of life. So there are some reports that suggest that if there's an agenesis of the gallbladder, that there's an increased risk for trisomy 18 or 21 or cystic fibrosis. Most of the time it's just a normal variant, or that we just couldn't see it at that time. But I mean, when you're doing that survey, the things you should be looking for: gallbladder, stomach, bladder. Because again, those things, should change over time. We look at the abdominal cord inserts, so we're trying to look at the ventral wall. So here we have the baby's head, the spine, and there's the umbilical cord coming right into that ventral wall. And when we're evaluating this, we want to look at it both sagittally and transversely. And when you're looking at cord insertion, you want to make sure that you do see amniotic fluid on either side of that cord insert. If you've got a limb pulled up there and you can't see the anterior wall, there could be a defect there that you missed just because the limb is in there. So if you can't see it, document it that it was not clearly seen. So cord insertion into the abdomen is different than looking for how many umbilical arteries that I have. Those are two different images. This is your abdominal wall cord insert, and then when you're looking for how many vessels are in that cord, then go down to the bladder and look with the color to see how many umbilical arteries you have there. So transverse of the pelvis. Now I'm looking at, yes, I'm seeing part of the cord here, but I'm not seeing the umbilical vein. I'm seeing the arteries here, both of the arteries coming off the iliacs, carrying the blood from the baby's body back to the cord. So there are two different images, two different sites. The other way you can document, especially in the third trimester when it's hard to get the arteries around the bladder because of shadowing from the pelvic bones, is you can just go to a cross section of the cord documenting that, yes, the vein should be the larger of the two, and then the two arteries. So the umbilical vein and then both arteries. Now, when you have a single umbilical artery, then you can have these vessels are almost equal in size. Because there's only one artery, then the artery is almost the same size as the vein. So some of our ventral wall defects, the two main ones that we're going to cover is going to be omphalocele and gastroschisis. Omphalocele is a central defect. The cord inserts into the defect. And other anomalies are very common with omphalocele, and it has a high risk for aneuploidy. Gastroschisis, on the other hand, is a periumbilical defect. So the cord inserts into the abdomen normally, and there's a defect usually to the right of the cord. Other anomalies are very uncommon, and it has a low risk for aneuploidy. It has a high rate of bowel complications, though, obstructions, because it twists and turns, because it's just floating out in the amniotic cavity. So it can be seen in association with substance abuse and some medication use. So omphalocele, the incidence is about 1 in 4,000 births. So we see as we're following along the anterior abdominal wall, we see a defect here. The cord inserts into the defect, and we can have abdominal contents herniated out into the base. So abdominal contents that we can see is usually the bowel and the liver. It's covered by a membrane, peritoneum and the amnion. It's associated with cord cysts and increased Wharton's jelly. So that cord's going to look a little thicker, and you can have cyst right along the cord insertion into the defect. And then these are just different images of some omphalocele. So we're looking at the spine back here. This is a rather large defect, and you can see even the heart is being pulled inferiorly and towards this defect. Another transverse of the abdomen, looking at the spine. So we can see stomach. The majority of the liver is out. Here's bowel here. So again, and then there's this big increased Wharton's jelly as covering this area of the liver. So you can see how much there's almost more abdominal contents out of the abdomen than in. This is a medium-sized one. Again, looking at the spine here and looking at bowel herniated out there. And this one, look at the abdominal contents herniated out are bigger than what's left in. So you try to document, you go through, put on color, try to see exactly what's herniated out into the defect. Bowel usually does not thicken or dilate with an omphalocele. The smaller omphalocele or defects have a higher risk of aneuploidy. A larger defect is going to contain multiple organs, and you're going to have eccentric cord insertion into the defect. It's not always going to be in the center of the defect. Sometimes it's inferior, sometimes it's superior. More likely inferior and off to one side or the other, but it's still the cord inserts into the defect. And with your large omphalocele, you can actually get some scoliosis. So here's a transverse of the abdomen. This person came in, she was only there for AMA, but when we're scanning, the only thing that we saw was just at the umbilical cord insertion. This is why you need to look at this, the insertion site separate from the bladder. It's just this little bit of bowel herniated out right into the base of the cord. See it right here? So you put your color on, so right there. This omphalocele after the baby's born. So you can see, look, cord insert is right down here, but it's still into the defect. But they're not always going to be right into the center of the defect, okay? They can be eccentric. When there is an omphalocele identified, they have other anomalies in 50 to 80% of the cases. 20% of those are going to be cardiac in origin. Chromosome anomalies, again, in 40 to 60%. Approximately 30% are going to be trisomy 13 or 18, and IUG are demonstrated in about 20% of these babies. So gastroschisis, on the other hand, has about a 1 in 3,000 births, the incidence. You usually have cord insertion into the abdomen, normally with a defect, usually to the right of the cord. So the cord comes into the abdomen normally. There's no membrane over the bowel is just floating within the amniotic fluid. So it's a transverse, again, looking at the spine here, and then we just see bowel floating in the fluid. And as that goes along and progresses, you can see some dilatation to some of the segments of the bowel. It's less likely for organ herniation. Usually it's just bowel, but usually the liver is not involved in this. There's variable amounts of bowel herniation. The bowel just floats around in the amniotic fluid, so you want to assess it again in 3 planes. And this is what it looks like once the baby's born. So other anomalies in only about 10%. It's usually normal chromosomes. So if we see gastroschisis and we don't see anything else, the physician will always talk to them and offer them a karyotype if they want, but they tell them most of the time it's normal. So we kind of just leave that up to the patient and let them go home and think about it and let us know what they want to do. So what we do worry about with a gastroschisis is that the bowel can twist, and you can have torsion, you can have focal dilatation, you can have dilatation inside and outside the abdomen. So don't just concentrate on the bowel that's floating out in the amniotic fluid. You want to look to see if there's some dilatation to the bowel that's left in the abdomen also, and then document both of those. So they're at an increased risk for ischemia and obstruction. And this is what that looks like once the babies are born. So that ruptured omphalocele can resemble gastroschisis, but remember, usually gastroschisis doesn't have the liver out. So if you've got a lot of organs out and you have that scoliosis of the spine, think maybe that it could have been a ruptured omphalocele. Ectopia cordis is where you have, it's a rare malformation, protrusion of the heart through the chest wall, has a higher association with pentalogy of Cantrell. And this is what that looks like. There's that cross-section of the chest with the heart, and you can see how the ventricles are herniated out through the chest because of a sternal defect. Okay, pentalogy of Cantrell has 5 anomalies. It's a defect in the lower sternum, a deficient anterior diaphragm, a deficient diaphragmatic pericardium, and intracardiac abnormalities. So it's a combination of all of this that's going to give us the pentalogy of Cantrell. And it's a midline supra-umbilical abdominal wall defect. So these are not subtle. It's usually, a large amount that's involved. So ultrasound findings are the ectopic or ectopia cordis, the midline anterior wall defect, pericardial pleural effusions. They can have craniofacial abnormalities, ascites, and high association with a single umbilical artery. So limb-body wall complex is also known as a body stock anomaly. That's a failure of the whole ventral wall to close. It's often left-sided. So the big difference with this is that they almost look like a limb body. They almost look like an amniotic band, but they have a very short or absent umbilical cord. Sometimes it feels like the baby's attached. You can never get the baby separated away from the placenta. The organs are in a sac outside of the abdominal cavity. It's a disruptive abnormality, and this is going to be a fatal thing. So you can see how the baby's just kind of like stuck over by the placenta there, even though the baby was moving early on, never pulled away from that. So what you can do is you can roll mom either right side or left side, and try to see if you can get the baby to move away from there, from the uterine wall. So it's an abdominal schisis. You can have amniotic bands attached broadly to the fetus and the placenta. You have evisceration of the liver and the bowel, and you have a distorted body axis. So looking at the head and the spine here, and liver and bowel just kind of hanging out there and very kind of attached right here to the placenta. It also has an association with limb defects. 95% of them are going to have limb abnormalities. The severe scoliosis, again, because they're attached as they're growing, they're being pulled, trying to get away from the placenta, but they can't. Craniofacial abnormalities, other organ malformations, renal abnormalities, amniotic band is about 40%, but they usually have a normal karyotype. So this is just a scan of babies from the head to the little tush. And at the placenta, you can see these amniotic bands attached to different segments. Look at this large band going right through the back of the head. And then just looking at it transversely. Again, those bands attached to different segments of the head and face. So some of the sonography pitfalls that we can have when we're looking at the abdominal circumference and looking at the abdominal wall is mismeasurement of the abdominal circumference. The AC is going to be our single best measurement for detection of good or poor fetal growth. So if the baby's got good blood supply and is growing well, the tummy will be the first thing to overgrow. But if we're having poor growth or poor blood supply to that baby, then the tummy's going to be small because the baby's going to automatically shunt blood up to the brain to keep the brain and the heart going. And so the tummy will sacrifice. It's the easiest biometric measurement for us to measure inaccurately. So anytime the spine is straight up or straight down, then we tend to underestimate the AC measurement. So you actually want to have the spine off to one side or the other. In the third trimester, when there's decreased fluid or the baby is just big, you have fetal crowding, then it's hard for us to get a good AC measurement. So again, maybe roll your mom to one side or the other. Try to get that baby away from the uterine wall so you can try to get a better AC measurement. Make sure that's not compressed too much. And then when you measure it with the spine straight up or down, that tends to foreshorten your measurement also. So sometimes in the third trimester, you can get what's called pseudoascites. It's just a hypoechoic rim underneath the skin, and it's just abdominal musculature. It's not really ascites. If it's true ascites, go ahead and roll them, roll the baby, roll mom, and it really should move if it's truly ascites. So change your scan plane and reassess. Always make sure you're evaluating the abdomen, at least the transverse and sagittal projections. The coronal is very helpful also. All right, so true ascites, you can see how the skin is pulled far away, and we can see this hypoechoic space with the liver and the stomach seen posteriorly. And you can just see the bowel moving around in here. So anytime you see the abdominal anatomy too well, then start thinking that there might be some free fluid in that abdomen. And this one's showing, look at how you can highlight the diaphragm, because not only is there abdominal ascites, then there's pleural effusions also, and you can just see how that whole diaphragm is being evaluated. So one of the pitfalls that we can have it's called a pseudo-omphalocele, when there's too much compression, either from not as much fluid around the baby, or when we're just pressing too hard, because we know if we press harder and get closer to the baby's anatomy, we can usually get a clearer image. But sometimes we can actually compress too much, and see how you almost make it look like it's an omphalocele. But it wasn't. It was just compression. I went back and rolled the patient to the side, didn't press as hard. It was a normal abdomen. So just be careful that whenever there's decreased fluid or fetal crowding in the third trimester and you're pressing hard, especially on your larger moms, and you're trying to get this good AC measurement, you can artificially create what looks like an omphalocele when it's not. So always decrease your pressure, roll them to the side, and then try to get the contours again. All right, so looking at the transverse of the abdomen, looking from posterior to anterior, we see from left to right. So what are the two technical errors that we can see here? Why would you say this is not a good AC? Well, number one, look how you kind of obliged, because look how I can trace this almost all the way to the anterior abdominal wall. So we know that that cord insertion is down lower. I want to be up higher. So it's oblique down to the side. And then the other thing is, look how I'm compressing this anterior wall from pressing. So those are two technical tips. So I try to, you have some compression from the knees being pulled up here, but we really shouldn't be pressing so hard that we're flattening out part of the abdomen. So again, back off on the pressure, roll mom if you need to, and try to reassess. So you only want to see the little part of the left portal vein going to the right portal vein, curving away from the stomach. You don't want to be able to trace it all the way back to the anterior abdominal wall, because then instead of coming into a true axial of the abdomen, you're actually tilted down. So now you're going to make your AC artificially larger than what it really is. So just really pay attention to your landmarks. And this is why we do all of this, to get these little babies at the end. So they get to come back and we get to play with them once they're born.